Welcome to Global Medical Office Dialogues. Cardiovascular disease. It's the #1 cause of death for people with kidney disease. Over the past 60 years, since the origin of chronic dialysis, we've effectively eliminated kidney failure as a cause of death. But in its place, we're left with malignant cardiac disease. Joining me today on Dialogues are Drs. Canaud and Allan Collins, Senior Chief Scientists at Fresenius Medical Care. Welcome, gentlemen. You all are experts on kidney disease and on its impact on the heart. Let's start with you, Allan. Tell me why cardiac disease is such a problem in our kidney failure patients.
Well, what's been known for decades now is hypertension is present in about 80 to 90% of the patients who start end-stage renal disease. And that hypertension control is really quite difficult. Volume overload contributes to hypertension, but the cyclical nature of the therapy 3 times a week allows this fluid to accumulate, and then we remove it and accumulate, thereby exacerbating the hypertension and the structures of the heart, which ultimately lead to heart failure.
Tell me what cardioprotection actually means. When we say that, what are we actually talking about?
So we have 2 dimensions of cardioprotection that we really have to deal with. One is intervention, where those who have cardiac disease and are getting worse, where we come up with an alternative way of treating them to ameliorate some of their signs and symptoms and improve their stability on dialysis treatment. The second element, which is more primary prevention, is how can we take incident patients and treat them more effectively to prevent them from getting the cardiac and progressive cardiac complications that have been present and noted in the prevalent dialysis population.
Bernard, I have a question for you around the nature of the cardiac disease across the various stages of CKD. We see that atherosclerotic disease versus pump dysfunction and other volume stress and rhythm-related disturbances happen at different times. Can you discuss a little bit about your thoughts about the different types of cardiac disease on the various stages or vintage of the patients that we see?
That's a good question, because we know also for several decades not the cardiovascular disease progress at the same rate as the CKD progression. So we know that there is a sort of CKD CVD process, meaning at the end, as soon as you do something on a CKD to reduce progression of this chronic kidney disease, this is beneficial on a cardiac system. And as Allan mentioned, we have different elements. One is, of course, salt accumulation, meaning I would say salt, volume, pressure, meaning this is a mechanical stress, which is coming on the vasculature system and particularly on the heart. But also we have different elements which are a little bit more on metabolic aspect. And we know that CKD or chronic kidney disease, all this, I would say, abnormality coming with the uremic state is part of the inflammation, part of the oxidative stress, part of these lipid disorders. Maybe anemia is another element. So we have some mechanical element and some metabolic factors who can, I would say, facilitate or I would say modify the progression of cardiovascular disease and also the chronic kidney disease. So intervention not only have to make a reduction about this fluid overload, as Allan mentioned, we know that salt dietary intake is a very important one. So we have to act on this dietitian aspect, but also on the diuretics, we have to act on this pressure. So this is one aspect to prevent the mechanical, I would say, consequences, but also we need to act on different elements, as I mentioned. Inflammation, oxidative stress, anemia are perfectly, I would say, known as factors of progression on the vascular disease. So the heart is reflecting all these, I would say, elements. So mechanical, inflammation, oxidative stress, anemia should be at some point, I would say, counteract by different ways. So it's part of the diet, it's part of the medication, it's part of the anemia correction.
So let's roll back just a little bit to earlier stages of CKD. We know that more people die of cardiac disease in mid to late stage CKD than ever progress to end stage kidney disease. If you're a practicing physician, nephrologist at that time, what should be your focus? Is it atherosclerotic disease? Is it volume and pump dysfunction? Tell me a little bit about your thoughts about that earlier stage CKD patient and when the cardiac disease needs intervention in these days.
So that's also part of the, I would say, intervention that we can provide. I would say the first step is how to control salt intake, because as we know, salt is a tremendous, I would say, factors for depression, for the hypertension, but also from different elements. So I would say diet, education, diet, intervention, plus then on the medication side to reduce, I would say, this salt, fluid overload and pressure, acting on the diuretics, acting on ARBs, or I would say medication acting on the renin-angiotensin system to reduce this mechanical action on the vasculature, so meaning reducing atherosclerotic, because we know that early stage of CKD is not the atheromatosis, it's a little bit more on sclerosis on the vascular and on the myocardium. So acting on the mechanical aspect is certainly very important. So part of this element. And also next, when you get stage, I would say 3 or 3B, for example, anemic patient, acting on the anemia is also very important to reduce such cardiovascular stress.
So Allan, let's segue to the next phase of a patient's life and journey with kidney disease. An incident patient suffers a variety of challenges depending on the mode of therapy that they initiate dialysis with. What are some of the cardioprotection sort of features that you think need special attention from nephrologists during the incident period? We'll talk about the prevalent period later.
So while I was at USRDS, we published a number of papers that looked at the transitional period and how big a risk that was. Strokes go up near initiation, myocardial infarcts go up, heart failure hospitalizations go up, and arrhythmias, et cetera, which Bernard mentioned are sources of metabolic control issues. So the real challenge for the nephrologist is, what tools do I have that I can actually use to help mitigate some of these problems? And within nephrology, there is a conflict that is actually going on right now. Do you use the best cardioprotective drugs that the cardiologists have shown in the non-CKD and dialysis population, ACEs, ARBs, mineralocorticoid receptor antagonists, renin inhibitors, to treat heart failure and to control blood pressures? Or as CKD progresses, there are those who have said those drugs actually reduce kidney function and therefore should be stopped. And when you look at the data that looks at how the medication profile is changing during the incident period, when patients go from stage 4 or 5 onto dialysis, there is a dramatic fall in the uses of ACEs, ARBs, mineralocorticoid receptor antagonists, and a large increase in the use of calcium channel blockers and diuretics, which is really this dilemma that heart failure is the #1 hospitalization, and hypertension is really difficult to control. So in the current era, the challenge has been, well, what are you going to do? And what I think Bernard and I have tried to articulate is the mechanical aspects of salt and water and volume overload contributing to hypertension are really the core issues that we'll have to address. And we'll have to do that in a way that allows us to use these cardioprotective medications to help us, given the fact that the dialysis population has a dialysis schedule that is not physiologic by any standard.
So let's actually segue a little bit to the physiology of the prevalent patient on dialysis, and the majority of those people are on hemodialysis or some version of that. Talk a little bit about the long interdialytic interval, the 3-day per week sessions that we have, the concepts around frequent hemodialysis and its impact on cardioprotection, because it strikes me that we are in a position to look at these somewhat differently than we have in the past, knowing that 51% of cardiac deaths are in fact from individuals that have rhythm disturbances. So
I think the sudden death issue as being the dominant cause of death from cardiac disease sort of masks the underlying phenomenon that this 3 times a week cycle of volume up, volume down, volume up, and then over the long interval, volume way up, is really stressing the myocardium, and it's stretching the atrium. And the cardiologists have shown us more than 20 years ago that if you stretch the atria, you get atrial fibrillation, which is among the most common rhythm disorders in the 12 hours before you start dialysis. Interestingly enough, other rhythm disorders actually occur during or at the end of the dialysis session, but they're not as common as atrial fibrillation, which really looks like a volume stretching phenomenon of the atrium. So from that standpoint, the control of the salt and water that Bernard talked about by a whole host of tools that are available would be central to the improvement of controlling hypertension and controlling the volume effects on the heart.
I'll throw this out to both of you and have either of you. We've read some of the literature on this parasympathetic system, sympathetic system imbalance that occurs as you get further away from your last dialysis treatment. To what degree do you think this sympathetic overdrive and imbalance is responsible for some of the rhythm disturbances that we're seeing that can be part of that sudden cardiac death problem?
That's certainly a good point, because we know that there is a tremendous higher sympathetic activity in dialysis patients, not only in dialysis patients, but in CKD in the advanced stages. So this is part of the manifestation of the arrhythmia, certainly the change in the QT interval and the different element, but not only on the cardiac, because there are also some, I would say, links with some, I would say, sleep disorders, sleep abnormality, meaning that at the end, sleep apnea could be also linked to this abnormality. So certainly we have to act on this element. We miss a lot of information because, as Alan mentioned, a lot of arrhythmia can occur during the dialysis session or close to the dialysis session, but the sudden death, which is coming during the night of the patient, is not linked to the dialysis. So that could be sort of over-sympathetic activity, I would say, could impact the patient outside the dialysis, and certainly the sleep disorders that we are detecting now are part of the game. So how to correct this sympathetic activity, that's a different story. Maybe increasing treatment time, maybe increasing the frequency or reducing stress during dialysis, maybe using different technique, as you mentioned about the hemodialysis, for example, but still we don't have a lot of data supporting this element today.
Alan, we're living in a connected health environment right now. Should we be monitoring our patients because we know they have these increased risks for AFib or bradycardia or other rhythm disturbances, some of which are quite onerous?
So the challenge has been that many of us have done these monitoring exercises and have been unable to intervene. In fact, there was a clinical trial done with a wearable cardiac defibrillator device to see whether or not that would improve it. I think the nature of the arrhythmias, which Bernard is pointing out, is critical to understand. Bradyarrhythmias and asystole is the most common cause of sudden death. It's not clear what we're supposed to do to figure out how to prevent that. That is not clear. The atrial fibrillation is a little more straightforward in that atrial stretch within the 12 hours before dialysis looks like a reasonable mechanism by which that atrial fibrillation is being precipitated. But Bernard, perhaps you could comment on what do you think about this bradycardia and asystole that's actually going on in the post-dialysis period?
Yeah, sure, but that's certainly reduced. For example, if you take, I would say, nocturnal hemodialysis with 8 hours or 12 hours, so you reduce the fluid overload, you reduce the mechanical stress that you mentioned. that's certainly a very important factor, but need time, because if you look on the echocardiography or different, I would say, hemodynamic change in the cardiac system, needs several months to recover from this time. So at the end, we cannot change, I would say, this abnormality, atrial fibrillation or bradioarrhythmia or asystole, just by changing the treatment profile. It will take time, but certainly that's treatment time, or maybe the frequency of the treatment, would be an important factor. In addition to, I would say, maybe medication, but beta blockers could be part of the game, but certainly not as a first approach, because we know that dialysis-induced stress plus treatment time are very important in this approach, as you mentioned. So the mechanical factors is really important.
So Bernard, just expand a little more on what you think nephrologists can do in adjusting their dialysis prescriptions to try to mitigate or minimize or ameliorate the cardiac risk that our patients have. What would be some practical points?
That's also a very important question that we tried to address by different, I would say, studies recently. But one is, of course, I don't want to remind, the time is a very important one. The time, treatment time, but the frequency. And certainly when you reduce this, as you mentioned, this 3 days interval, that's very important, because we know that a lot of issues are coming at the end of this 3 days interval. So the treatment time, but also the way of managing the patient, because too aggressive way of managing the patient is not good. We talk about the volume overload and the volume depletion, meaning hypovolemic condition. But the fourth element we didn't talk about is electrolyte shift during the dialysis session. And for example, we know that potassium changes if you move from 6 to 2 millimoles. And at the same time, you move from acidotic status to alkalotic, plus from hypocalcemia to hypercalcemia, and to hypomagnesemia to hypermagnesemia. So you have a tremendous, I would say, cocktails who can certainly facilitate this type of abnormality. So recommendation is to act on the time, to act on this change within the electrolyte balancing, maybe on the sodium, and there is some, I would say, new up with this isonatremic condition. And certainly also we have to act maybe in very specific categories of patients, maybe on a different way of managing the patient. If the patient, as Alan mentioned, is a cardiac one, we need to personalize the treatment, maybe to extend the treatment time, or to add additional session, or to maybe add isolated detraffication out of the 3 sessions a week, just to make a very personalized care. There is not a magic treatment who can fit all at the same time. This is not possible, but certainly, depending on the patient risk, we can have a different type of approach for providing the best treatment of the patient.
Before we wind up this short segment on cardioprotection, I want to throw out to you all a question that I know you all are going to be writing about in our annual medical report this year, and that is, what do you think the impact on cardiac protection that the SGLT2 inhibitors and some of the other newer drugs that may also be helpful in delaying CKD progression? I actually have believed that their cardiac impact may be greater than their renal impact, but what are your all's thoughts about these? Alan?
Well, Bernard and I have been recently discussing this as our topic for the annual medical report. What is quite interesting about the SGLT2 inhibitors is what they do to sodium and glucose loss in the kidneys. But not only that, there appears to be an effect on skin sodium, so-called non-aqueous sodium content in the skin, which is quite different than all the other drug classes that have been used, diuretics, ACEs, and ARBs. And it appears to have an effect on that. I think Bernard may want to comment on this. So that these drugs not only appear to work on volume through osmotic diuresis with the glucose and the sodium loss, but may also have more direct effects in the skin and other cellular mechanisms on hypertension, which are not related to volume directly.
Correct. That's exactly the point. We had an exchange with Alan, and I'm completely convinced, and as Frank mentioned, that SGLT2 inhibitors would be a fantastic drug for the chronic kidney disease patient, not necessarily from the diabetic, I would say, origin, but certainly that would be beneficial in the stage, I would say, 3 to 4 to 5. So what would be the question now? Does this medication would be applicable to dialysis patient? And I'm not sure, because of course, if you look on the mechanism of action, we don't see any beneficial effect with these drugs in a patient who has no kidney function. But okay, again, we need to make an evaluation on this element. The first certainly interesting fact is related to diabetic patient. And as soon as you check, and there was a study 2 years ago monitoring sodium skin based on MRI, showing that the most beneficial effect of the SGLT2 inhibitors in diabetic patient was not on the glucose control, but on the sodium, and not only on the sodium in terms of osmotically active, but on the sodium stored in the skin, meaning at the end they reduce, I would say, inflammation, they reduce oxidative stress, and facilitate the action of the insulin. So insulin resistance is part of the sodium accumulation in the skin. So at the end, we have some new insight, meaning that treating CKD patient earlier, I would say stage 3 to 5, maybe will bring the patient to the end stage of the kidney disease in a better shape, meaning that maybe the transition, as Alan mentioned, would be a little bit more harmful for the patient. So that could be a new op, but need to be validated by any study. We don't have the answer to this. This is clear.
Thank you, Bernard. And as we know, these particular drugs are identified predominantly for earlier stage kidney disease and have some potential risks in very late stage kidney disease. But it's clearly one of the questions where I think throughout the whole continuum, this malignant cardiovascular disease is a substantial issue that I'm sure we will have progressive and more dialogue with our nephrology partners around the world. I want to thank both of you today. I've been with Dr. Bernard Canaud and Dr. Allan Collins talking about cardioprotection for kidney disease. And we want to thank you both for joining me today on Dialogues.
Thank you, Frank.
Thank you very much.